David, do you want to maybe just frame for our audience here and our 900 or some odd hospitals that are on around the world, what the findings were as they apply to the NTSB concept?
Sure. So the backdrop is that our committee was asked to evaluate the problem of new errors being created by HIT systems. There have been a series of studies that suggest that if you use health information technology, that care gets better. But there have also been a series of reports that emerged that show that health information technology can have unintended consequences. It can create new problems. And so we were asked to address this. We reviewed the evidence that it can create new issues. As far as I know, it is on. It is not on. Okay. So should I take it from the top, or do you want me to?
Quick recap.
Okay. So our panel was asked to address the issue that health information technology can create new errors as well as prevent them. And one thing that emerged was that when providers do find these new issues, there's really not a place to report them. And it's been very difficult, in fact, for providers to share these issues. And our panel, therefore, made the recommendation that it would be helpful to create something like a National Transportation Safety Board analog that providers could report to with these errors. They could then be freely shared, and people could learn from the error reports. That's been extremely successful in aviation, as I think you'll hear from some of the rest of the panel.
Thank you. And I'm going to jump around in our panel order here and go to Captain Sully Sullenberger, retired captain. We all know Sully for really being a terrific example of great leadership. What most people don't know is how thoroughly trained and knowledgeable he is about performance engineering, and so many of the things that we really need to know about in patient safety. 20,000 hours as a pilot, a terrific history for those of us that are pilots. You know, he's got all the credentials and has also been actively involved with the National Transportation Safety Board, and I think has great passion for this. And then we'll go to John Nance, also an accomplished pilot. But Sully, most people are absolutely shocked that we don't have a National Transportation Safety Board-like entity of any type to aggregate knowledge and to learn from these accidents that have really written the rules in blood that we follow in aviation.
It is shocking that we don't. And let me tell you, in aviation, what a difference it made that we finally had one decades ago. In the bad old days, it was far too easy for accident investigators simply to blame dead pilots for individual practitioner errors and leave it at that. Never do root causes analysis, and I say causes and not cause because there's almost always more than one root cause. And when we don't do root causes analysis, identify and correct systemic deficiencies, we do not solve the underlying issues, and we do not do all we could to prevent accidents from happening again. As Chuck said, almost everything we do in aviation, every rule we have, every procedure we have, everything we know, we have because someone somewhere died. We literally have lessons purchased at great cost, literally bought in blood, that from a moral obligation standpoint, we cannot afford to have to relearn. Thankfully, with the NTSB formal lessons learned process, we began to get away from pilot error as a dead end, a catch-all, literally a dead end. We began to do systems analysis. We began to understand that nothing happens in a vacuum. We began to do underlying system issues and correct them. We began to transition from a culture of blame, which drives problems underground where they can never be identified and solved, to a more just culture in which accountability and learning can be balanced. And so that was the transition we made in aviation that was critical. That plus the creation in the mid-1970s of the NASA Aviation Safety Reporting System that provided a de-identified means and an incentive for practitioners to report safety deficiencies, their own errors, free from repercussion.
So the moment that we hear that there might be a recommendation from an esteemed group like the Institute of Medicine that makes a recommendation to the government is, immediately, we can't afford another agency is the first thing that pops into your mind. But no one really knows what it'll cost. And in the article that Sully and I and John Nance and Dennis Quaid wrote, and in the follow-on article, Jim Bajan will be the fifth author to expand this, we undertook a pretty detailed analysis of the evidence and actually also looked at the finances. And the NTSB operates at about 30 cents, 30 pennies per citizen. Now taxpayers have all paid for those best practices, so they're transportable, they're public domain, we would think, and there's knowledge and institutional knowledge that could be applied. And so we're really not proposing another agency. What about a public-private partnership? What about a private one? What about an industry-wide approach that might cost a nickel or a dime per citizen? And the evidence is there, and the numbers are there, and the results are there. John, frame the concept that you brought to us of a red cover report.
Basically, when you look at the NTSB, and by the way, that's all forms of transportation, not just aviation, but that 30 cents, and you look at one of their major work products, there's something very interesting that I noted from the beginnings as a professional pilot, and that is if you lean in a pilot lounge and throw a couple of so-called blue cover reports in, be prepared to jump back, because we as pilots will dive for those reports because we want to find out what somebody did wrong so we won't do it wrong too. There is no source like this in medicine. So the red cover report idea is basically an extrapolation. It's an extrapolation of the intellectual rigor of a report that the way the NTSB does it. They don't call it a blue cover, by the way, but that's what we all call it. A red cover report would simply say we're going to take a look at a select number, not everyone, we couldn't possibly humanly do this, but at select numbers of representative mistakes, errors, problems, disasters in healthcare, and we're going to take them apart with a philosophical approach, which is now standard at the NTSB, which says that there's not one cause, as Sully mentioned, never one cause. Secondly, we're not interested in blame at all, under any circumstances. Blame is for the lawyers to hash out later. We want to know everything that happened and contributed to what occurred. Everything that could have been done that wasn't, as well as everything that did get done that became a contributing factor. You do just the facts, ma'am, as the first part. Then you get into an analysis of the facts. Again, no blame, no finger pointing, no names. You can de-identify these. And then you take that analysis into recommendations and into also an extrapolation of the causal chain, which is usually, for just any complex accident or incident, going to be 10, 20, maybe even 30 different contributing factors. And here's one of the most important points that came out of the NTSB's maturation over time, as personified by these blue covers that we want to recreate in a red cover. And that is that every single solitary link in that causal chain, or every hole in Jim Reason's Swiss cheese slices, will absolutely form the nexus of another accident, incident, or disaster, or in other words, it will become a causal chain element if it is not snipped away. So when you just look at one, you're not solving anything but that one accident. It's like firing somebody because they're the one that made the mistake. It gives you a warm feeling, it accomplishes nothing. When you take care of every one of those links, in one fell swoop, you eliminate for the entire industry the ignorance that these things can contribute to a major problem. And I think in healthcare, since we have nothing like this, that we literally have not just a burning platform, we have a house on fire in desperate need.
And in our article, we said we didn't make the case to do it. We made the case for why aren't we doing it?
Yeah.
Like, what is the case for not doing it when you already know all the, you know how to do it, you know the methods. And so I come to David Klassen and this issue of the socio-technical model, and you have frontline experience in seeing these accidents happening, and you've written about the fact that the unintended consequences of these new great breakthroughs and the technologies, and Farzad will come to you about what you're trying to do to disseminate them, but the risk-benefit, just like any new thing that we put in jet, Dennis Quaid and I kind of laugh being around you two. We're a couple of guys with 2,500, 3,000 hours in private jet time, and you all are, the giants in aviation. just as we look at the aviation crossover, David, you're seeing the unintended consequences we did when we brought in new instrumentation in airplanes, when we advanced some new way of going faster or higher or do something new. There are unintended consequences, and you're seeing that at the sharp end. Is that a fair statement?
Yeah, that is a fair statement. I've been involved in accident investigations around health information technology, both inside organizations and outside organizations, as an outsider looking in. And the perspective is very different. When you're inside an organization, even when you think you're doing a good root cause analysis, you always end up rounding up the usual suspects and identifying the usual suspects, which is usually a person. And you don't usually get, even with RCAs, to all the many factors that contribute. I think that's natural within organizations. It's a real challenge. And if you do get to the real causes, you almost never share them nationally, so other people don't learn from your mistake, despite all that we've done. So I think the future will be, how do we create a learning system, and a learning system that doesn't relegate us to silos? When we have an HIT-related accident, we look at HIT problems. We're not thinking always about the organizational problems, the people problems, the workflow problems, the external forces that play a role in causing that accident. And I think that's something that we could really use great improvements and iterations that would come from an external board that would have that capability to look at life as a socio-technical system rather than just a slice of IT. So in the IOM report, we talk about this socio-technical model, about a new way to think about safety that goes beyond just the IT system to a much larger socio-technical model that wraps in people, process, organization, external factors. I think that's probably what you've learned from NTSB, is that much larger model is what needs to frame the perspective on an accident investigation. Unfortunately, we often don't do that in healthcare with our RCAs, our root cause analyses.
You're exactly right, and these report findings must be widely disseminated, but also be locally actionable. And you're right, we found in aviation as well, with the increasing use of technology, in particular automation, that these things do not always solve all the errors. They, in fact, change the kinds of errors that are made. And so it's important that we realize, as you said, that we have a human technology organizational system, that all the parts have to play together well. We need to assign appropriate roles to the human and the technology parts that take into account our abilities and our limitations. And we need to have the end user involved in the system design from as early as possible.
One of the things I'm going to go for time. I'm going to go to Jim and Farsad. But what Jim, as we as you and I over the years have discussed the aerospace, as an astronaut, as an engineer, as a doctor, you were involved in the investigations of Challenger and Columbia. And in the movie that we produced, we could only take, one of the greatest dilemmas I had was almost all of you are in the movie, and it was so hard to pick and choose to just grab one bite or another bite. The expanded discussion about the NTSB for healthcare, where we did not put it in the film, Jim, if there was ever a push the envelope, create the new envelope socio-technical model, it was aerospace. My dad was a rocket scientist with the Apollo program, and there were lessons learned that you shared with me that we'll put in our toolbox about Challenger and Columbia, about communication and direct applicability, as Sully just said, actionable applicability. Would you share those with us?
Well, I think many of the things that are familiar to people from aviation and other industries as well is how do you go, and I like what Sully said, I think root cause analysis is a bad term. It's bad for several reasons. One, there's seldom, if ever, one root cause, and just to do analysis without action associated with it is kind of pointless. So, I mean, those are main things. Even when we were at the VA, in our National Center for Patient Safety, we actually try to do this, where we look at the myriad of causes, and it's not the person. If you stop there, it doesn't get the underlying thing, what led that person to be put in that situation, whether they were inadequately trained, if that was in fact the case. Why would we let them do something if they weren't competent? That's a systems property. That's not an individual property solely. I think even when we talk about the NTSB, which I think is a good model, I think we shouldn't restrict it just to health information technology, because the system is broader than that. If we just look at where the ones and zeros go, we miss the point, how we've missed the point many times. And we have to look at how does it interact with our entire system, how we deliver care. And the goal, it really is, as it was said earlier, it's to deliver high quality, safe care to the patient. That's the goal. All these things are just components that allow that to happen in a reliable way. I think the things we have to look at is how do we make sure that everybody thinks it's their job? How do they know when you report something that it'll be used appropriately, that it's not going to be to your own disservice and you'll feel like you're being treated unjustly, unfairly. How do we convert that to action, that people actually see that when they identify a vulnerability, a hole in the Swiss cheese, as John pointed out, that that's converted to actual action that mitigates that risk. Sometimes you can't totally eliminate it, but at least identifies it and mitigates it in a way, which means we also have to prioritize. If we don't say, how do we look at the reports we get and decide which are most important to do first, then we have kind of tyranny and chaos that people don't understand how we make decisions. That also helps us to tell people what's important. It also helps us as an organization or a system of organizations to what do we work on first. So we do it in a concerted, effective manner.
I'm going to stop for a moment. I'm going to go because you're a leader of the Office of the National Coordinator. But before we do, just so that we don't lose time, and I'm tired of the armchair critics that play journal club and say there isn't enough evidence for this and that and the other thing. Is there anybody in this room, we have some of the greatest leaders in patient safety in the globe in this room, is there anybody that wants to go on record that says there's not enough evidence for an NTSB for healthcare? Who wants to take that bite now? You got the people that could debate it. I didn't think so. I didn't think so, but you know what? We'll hear it, and we hear that going on, and we hear, is there anybody that doesn't think that a nickel or a dime or 15 cents per American citizen or a global citizen, we have World Health Organization, anybody want to go on record as saying there's not enough evidence? Because there's ample evidence. I led the National Quality Forum Safe Practices Development Program for, what, a decade. We put out a number of reports, and I went to the leadership of the NQF and I said, can we go out of industry? Absolutely. Can we go to papers that are not yet published but are going to be published? Absolutely. So this armchair critic, negativity on something that is so real and has such great face value, I don't think there'll be any takers in a national debate, but we'll hear this noise, and I just wanted to get that in the proceedings of this discussion. Yes, Jim?
I think not only do we need it, but the fact is about the cost. I think the cost is a bad way to term it. It's really an investment. There's a cost and a benefit, and we ran into this many years ago where people would say cost, and we'd always show them, yes, you must make an investment, but what do you gain on the other side? So to look at it as a pure cost, I think, is not a good way to look at it. Yes, there's cost involved, but it's not like we flush it down the toilet. Look at the harm, the inefficiencies, the human suffering, whatever. There's many ways you can do it in very financial terms to show it's foolish not to do so.
Absolutely. First, your position and your role in our government, would you share that with us first, and then your take on the balance of trying to get our nation wired and digital and taking advantage, and the unintended consequences and the risk and how we have to proceed wisely? But your role first, and then that
Sure.
approach.
I'm Dr. Farzad Mostashari. I'm the National Coordinator for Health IT. I'm the administration's lead for implementation of the adoption of electronic health records and the Nationwide Health Information Network. I also want to thank the gentleman who found my tweed jacket and bow tie in the park today. I'm going to collect it later.
So that those of you that are listening on the audio version of things, he's wearing a suit today and a tie.
Thank you. We just had a meeting in this building a couple of days ago, and it was to look at progress made in health IT. And there's been, depending on what group you look at and how you look at it, something like a doubling and a tripling of adoption among different kinds of healthcare providers, outpatient providers, inpatient providers, hospitals, small hospitals, rural hospitals. All the trends show a hockey stick curve up in adoption in the past 3 years. We've made more progress on health IT adoption than in the decades before. Recognizing, though, early on that we really, and Ashish Shah, one of David's colleagues at Harvard, summarized it. He said it's no longer a question of whether health IT improves quality or safety. The question now, this is a fact. Health IT adoption is a fact. The question is, how can it improve quality, safety, and efficiency, not whether. And in recognition of this, David Blumenthal, my predecessor, used to say that information is the lifeblood of medicine, and I think it's also probably the lifeblood of safety. And we asked the Institute of Medicine to take up this issue, that while we know that, as David said, health IT appropriately implemented can have tremendous gains in terms of quality and safety, how can we maximize its benefits, and how can we assure that we minimize any unintended consequences, any safety issues that come out as a result of the technology? On balance, we believe that health information technology is going to be a really critical factor for increasing safety of all sorts in healthcare, as a source of information, as a source of being able to share that information, reporting of safety events of all kinds. And I really applaud, I think, Jim saying, it can't be just about the safety of health IT. The question is really much broader, and the socio-technical aspects of how health IT fits into a broader system and the possibilities there. If we are rewiring healthcare, if we're taking a systems view of our delivery system that you have to do, if we're not just paving over the cow paths and digitizing the existing broken processes, if this is an opportunity for us to rewire, let's do it right. And let's use the health IT to not just improve reporting of safety events, but use health IT as an intervention to better systematize and to better reduce safety events of all kinds. That's the main goal that I think we have to hold on to. And I think what the IOM report really highlighted for us was there is simply a lack of information, a lack of reporting of not just the weather and the magnitude of any health IT related events, but really an understanding of what are the causes. And we have heard a lot that it's not enough to get reports. We have to be able to analyze and then intervene and keep that loop going. This is what we're very interested in.
So we'll come, Samantha, we'll come to you in a minute on the IOM and what it really is, because a lot of people, we talk about the IOM and we're not sure what that really is. But I want to go back to David Bates and David Klassen and say, number one, are there common accidents that occur that are common enough that if we had reports that all of us could look at, that we could prevent accidents from happening to others? Is it reasonable to take an NTSB type approach on a small number of very common accidents that are occurring in our hospitals that others could learn from? Is it, so both of you, are they frequent enough, you're nodding, and would that be of value? David.
I think that's definitely the case. When we do look across institutions, we find the same things happening again and again. We just did a study in 6 community hospitals in the Boston area and found that all of them had similar sorts of issues, and many of those could have been reported, and we could have rooted them out, had they been sharing and had they known about it.
David.
Yeah, and we know that medication safety is a big issue in most hospitals, and we know adequately dispensing and safely and reliably dispensing medications in a really production-driven system is also another area of risk. We've seen several problems around that. So that would be an issue that an NTSB-like approach might be very helpful with as well.
In our research that you saw in the film about imaging and the 5 rights of imaging, the right study, the right order, the right way, the right report, and the right action, is fraught with the most common things that occur in imaging happen in the laboratory. But the laboratorians are not talking to the guys in imaging, and the guys in various imaging departments aren't talking to the other guys in imaging. So we're seeing, even if we didn't do it in those areas, we would see it in imaging. Before I come back to you, Sam, Sully, when there's a new aircraft that comes online, in those first stages of deployment, do we or do we not learn about the squawks, and do the squawks represent risk, and do they get fixed, and do we share that broadly in aviation where we don't in healthcare?
Yes, to all. They provide sentinel events. They are precursors of probable future failures. We work very hard to get all the bugs out. And again, this is disseminated widely, but locally actionable. It's an important part of the safety system, this invisible hand that we see in aviation that we all operate in.
John, in the 80s, I owned an airplane manufacturing company and had to do the safety work for a fleet of 8,000 aircraft. And the FAA wasn't a regulator, it was a mentor, it was an advisor, it was a safety system, it was not a big brother as much as it was a kind brother that helped along the way with those accident investigations, and the rapid cycle way that we got out to that fleet when seats were breaking, people were falling back, it changed the center of gravity, and these airplanes were stalling and crashing. And we don't have that in healthcare. You've championed the cause before that the FAA is not just that big brother regulator.
Absolutely. As a matter of fact, the best use of a federal agency like the FAA, and they are unsung heroes for this over many, many years, is as a mentor. A good example of this is what we call crew resource management. Basically telling a captain you're not flying solo, you've got to bring your whole crew into it. It was a whole revolution and evolution in aviation. The FAA didn't write a rule on that for almost 20 years, and yet we had it completely deployed into the industry, but they were in the background mentoring and helping to push it along.
And this was an industry, and in our next session we'll talk about the application in aerospace, and I think NTSB will come back up. Sam, can you give our audience, because a lot of our folks, they hear about the IOM reports and we know that they're safety and quality, can you give us the framework to know what the Institute of Medicine is and what does it carry forth when a report like this comes out?
Absolutely.
You can even hold it.
I will hold it. Maybe a little prop. But so the Institute of Medicine is part of the National Academy of Sciences, which was chartered by Congress in Lincoln's day. And so we were chartered to be advisors to the nation on all matters related to science, engineering, and medicine. And so we are a membership organization, and we recruit members like David, and Jim to be part of these committees, to volunteer their time and look at the evidence and really try and get a better understanding of how we as a nation can move forward, and we make recommendations in these reports about what best the nation can do. And just to be really brief, is I think our biggest challenge with this report is that there's only so much that the IOM can do. There's only so much that FARSAT as the ONC can do. There's a lot of need for, we've thrown around the word system here today so many times, but I think each person who said it has meant it in a different way. But one thing that the report says is that we really need to better understand the larger socio-technical system, and that if all of the healthcare professionals and the organizations out there really understand what we mean by this larger socio-technical system, we'll make a long way in terms of improving safety.
Fantastic. I want to keep on time, but we're going to move into aerospace, and we want to keep our aerospace folks up here. And we'd also like, and David, we'd like to keep you here as well. We're going to talk about beyond checklists and what we can do in aviation and aerospace. Thank you, Sam, very much. If Perry Bechtel is here, since we have a mic. Perry, would you like to mic up and come up? Because one of our study foci in this last 6 to 12 months was in leadership, and it was fascinating what we learned with the Blue Angels. And what we learned about high-performance organizations, not so much from the pilot-aircraft interface, but leadership and the socio-technical model. And I'm going to ask Perry to kind of sit in with us and visit a former flight surgeon as well. Would you like to stay with us?
Sure.
Good.
I just wanted to take the opportunity to urge everybody to write in your comments to our proposed regulations for Stage 2 of the 2014 edition certification criteria for electronic health records. The comment period ends May 7th, and you can put your comments in through regulations.gov. I want to specifically highlight for the audience here who's interested in this topic 3 areas where we are specifically asking for comment in our certification rule. The first is a requirement that we're proposing that electronic health record designers use vendors who want to sell the products, use user-centered design in medication-related functions, 8 medication-related requirements for electronic health records. The second is that they report on what they're doing around good manufacturing practices, quality management processes. And the third is that they all have the capability to use the common format developed in collaboration with the Agency for Healthcare Research and Quality and the Federal Food and Drug Administration to report, to enable easy reporting on the part of providers of safety events of all types using that common format in electronic health records. These are some of the steps that we took the earliest opportunity to propose. These as a core part of the health IT landscape, and we would love your comments on these and other certification related.
Great. And this concept of the socio-technical model is, I think the report is terrific. And really, if you want to stay with us on the panels in the dialogue, because the aviation crossover and aerospace crossover absolutely has direct application. If Jim Bajan wants to come back up, direct application, the model really does make sense, and it gets a wider view of the end-to-end, systems sort of approach. Perry Bechtel is a flight surgeon, was a former flight surgeon with the Blue Angels, a neuroanesthesiologist at the Mayo Clinic Jacksonville, and if it hadn't been for Perry's great servant leadership, we would not have the Blue Angels in the film that some of you saw here in this room, and that'll be available tomorrow on the Discovery Channel, 8 a.m. local time. We found that the Blue Angels were a great example of great leadership. And the 4 T's that we found, Perry, that we talked about, that we've written about, the 3 T's, but the 4 T's were truth, trust, teamwork, and training. And what we saw at the Blue Angels was what we saw at the Barry Waymiller companies, the other example that we had, and also in government programs that were social entrepreneurship programs. And Perry, what we found was that truth is the currency of the head, the facts, figures, numbers, the science of what we do. At Barry Waymiller, it might be the lean methodology that they employ, and it might be another form of a PDSA in a hospital or whatever else. And that the second T was trust, engaging the heart. Hope, trust, the emotions, passion, joy, excitement, and we have that in aviation. And we all have this great feeling when we break through the clouds and we see this blue sky above, and flying is an emotional thing. The third T that we had was teamwork, and the fourth was very fascinating. The fourth T was training. And it was developing a voice from within. In every one of the high performers that we studied, the training was undertaken by those inside the organization. Brian Wellinghoff sitting here in front of me, they're training at Barry Waymiller. They didn't go outside to get professors. They made the people inside professors. We found that at Top Gun. We found that at the Blue Angels. Share for a moment the interesting turnover of the Blue Angels team. Everyone would think, well, this has to be a team that are so precise, and they must have been flying together for 10 years. Not so.
Sure, they act like they're flying together for 10 years, obviously, but the structure of it, every pilot and every officer that the flight surgeon, the maintenance officer, and the team changes every 2 years. You come on the team, you're on the team for 2 years, and then you're off the team at that point and go back out in the fleet and take some of those lessons from the Blue Angels out in the fleet. So that the training process is pretty intense, and there's a big investment that goes on in.
And you're trained by the guy whose place guy or gal whose place you're going to take.
Yes.
So there aren't the outside trainers. You're taught to train.
Yeah, it's sort of on-the-job training. It's very quick. You spend maybe the last 3 or 4 weeks on the road just learning the job, and then actually somebody who's on the team with you, who's a second-year team member, will train you. The maintenance officer trains the flight surgeon in his safety duties. The lead solo trains the opposing solo during that work. The number 2, when you have a new boss, when you have a new flight leader, it's actually the number 2 pilot and the number 4 pilot, who are second-year team members, who typically will train the new flight leader into what he has to do. Obviously, there's a big...
So the passion and what we found when we watched them train, because they had a new set coming in, was they saw the passion and the joy of the job. The joy of doing a great job was contagious, and it wasn't in a manual, and some trainer couldn't drop in and say, well, here's how you're going to fly next to the boss at about 3 feet from a wingtip, right?
Yeah, well, the model, which you see it a lot in aviation, you don't see it a lot in healthcare, is we like to drive decision-making, problem-solving, and communication down to the far ends of the organization. Because, and that's, the training is geared towards that, because the real life decisions are made at the very far end. A lot of times when we see healthcare improvement projects come through, there's still a lot of high-level decision making that goes on, and people will feed the communication end up, but the decisions made from above and then delivered back down. That's really not the model. The model is that the people on the ground are the most likely ones to be able to troubleshoot and make the decisions real time to make sure it's a safe program. You don't know if they, air show is a dynamic place. You don't know if they put poles at the end of the runway. That's not going to be noticed by somebody in the tower. It's going to be noticed by the guy working on the
Right.
runway.
So Sully, we've had this conversation before, and I'd love to have you share with this audience, the global audience, but also the audience here, in 208 seconds, life changed for you. You talk about the 3 things you did right, but my question is the question that you and I chatted about in a hangar up in San Francisco, and that is, is checklist all we have to learn from from aviation, or is it just the beginning? And then like to go to Jim Bajan and then back to John Nance. Checklist, is that all there is?
You're exactly right by saying it's everything beyond the checklist. And one quick note, many people don't realize that on the Hudson River flight, talking about changing the team all the time and acting like we've been flying together for 10 years, my first officer, Jeff Skiles, and I met each other for the very first time 3 days before that flight. And yet, if you'd been allowed to sit in our cockpit and watch us work that day on that flight, not that you would really have wanted to, I got you, you would have thought that we'd been working together for years because we were trained to such a high professional standard. We'd become essentially interchangeable. We knew so well and were deeply internalized these important responsibilities and roles to each other. But out of a 42-year career, 30 years at the airline where we worked very hard to make it routine and never be surprised by anything, we were suddenly confronted with the challenge of a lifetime. And all during that time, I never knew on which 208 seconds my entire career might be judged. And so I think that sort of understanding of the why, what's important, that diligence is what led us to have the system we needed in place that day to solve this problem we'd never seen before. But people sometimes think that the checklist in medicine, a surgical checklist, is an end in itself, instant in itself, but it's not. It's a means to an end. And a checklist is only effective if you have everything that it goes along with the effective use of it. You have to have the culture that it takes to use it well. You have to have the leadership, the ability to take a collection of individuals who may not even know each other and quickly form a team, align goals, create a shared sense of responsibility for the outcome. And so part of the effective use of the checklist is engaging everyone, having everyone who can respond to it. And it literally forces everyone to get on the same page. And when you do that, you can create a team. And who knew a piece of paper could do all that?
Jim, building on what Sully has just said, you are uniquely positioned, having been in space and aerospace, the real innovation, leading edge, also engineering, also a doctor. What are the next horizons for aerospace and aviation application to healthcare from where you sit today?
Well, I think many of the things you see in aviation also we're learning in other places even before. One of the things that I think we see a problem with checklists, as an example, is people think it's a magic bullet. That if I read these things, and a lot of people think you need to actually make a mark on a checklist, and a checklist isn't about that. You see John laughing. The checklist is a cognitive aid. It's a way, so as Sully said it very well, it's how do we have a shared mental model of what we're trying to do, what our various roles are, but it still allows us flexibility where we need it to attain the goal in a way that we can do it in a coordinated way. So if I was the first officer with Sully, he would expect me to take care of these functions. He doesn't have to check. If I'm going to do that, I'm going to run it. He understands that. I think in medicine, we've done the Cliff Notes version. We think, oh, checklist. I'll write a checklist and that'll make it so. Putting it on the wall or putting it in a book doesn't do it. It's all the stuff that goes with the culture, the shared responsibility, the actually focus on the goal. What is the goal? Sometimes I think we become too focused on being technically expert in our field, in our little silo. And we look at our goal is to do our particular piece of the puzzle correctly. And we forget how it fits in with everything else. And it's not enough for us to be technically correct. If I'm technically correct, but it doesn't interface with the other team members, and that includes the patient, then we don't get the right result. And I think often we don't give our practitioners, our caregivers, other people involved, the visibility to see how does their action integrate with others and get us to the actual desired end. It was said in one of the earlier panels about, it's almost like the golden rule, right? If I were the patient, if it was somebody I loved, would this be okay? And I think many times we're so busy, we don't ask that question. We say, I did my task. And my task isn't my task. My task is a component to render the patient the care that we think they should get. And often we don't address it that way, I think. And checklists help to have a shared mental model and do it, but it goes with, it's not just a piece of paper.
Well, in patients, and I just want to remind everybody, our hashtag is HIT, and I've been on one side of the days and can't read it from this direction, but we need to really bring them into the dialogue as much as we bring aviation in, and aviation and patients seeing it from that view, because they're air travelers and they see reliable and they see airlines that are nice to us and those that aren't, and they see that, that is a real view. And then the counterpoint is we're all patients. And I think the golden rule issue is one where we put on, if it was my little boy Charlie or my wife Betsy, and in my local community, we've had a medical error every year with almost every family member. And so, yeah, I'm a patient at the table too, but we don't think of that sometimes when we get so technical.
Chuck, one thing we did at the VA, we started a thing called the daily plan. And what we did is we extracted from the electronic health record those things that a patient or a patient's family could see. They would know if they were going to get a medication and when it was. They would know if they're going to get an x-ray or a treadmill or whatever it happened to be. And that would be briefed in a piece of paper that was HIPAA compliant and everything else to the patient and their family members or whoever they designated. And the nurse would brief it to them every day. And the nurse would tell them, if you don't get one of these things that it says you're supposed to get, you should call me. Or somebody wants to do something that I didn't tell you about, you should call me and don't let them do it. And we found that on any given nurse's shift, 17% of the shifts, there would be an act of omission or commission that the patient or patient's family discovered and would tell their nurse. These things would have slipped through, so it helped identify vulnerability we then could look at a system solution for, but it made the patient part of this. So this checklist, a fairly free-form checklist, allowed people in a very routinized way to know, here's what we're here to do. Everybody knew it that needed to know, and the person that really needed to know, in some ways, was the patient, because they're there for all the things. The nurse isn't there, the physician isn't there, the order isn't, but the patient happens to be there. Now, they can't all participate every time in the family, but it's one step that we often had not formally put as part of our system to help, deliver good care.
If I can pick up on that, as part of the requirements for meaningful use, right, for providers to get the health IT incentive payments, we have this thing called the after-visit summary. And this has been something that providers, particularly in small practices, have struggled the most with. Implementation of an after-visit summary, usually paper, where after the visit, the patient gets to see what are the medications the doctor thinks I'm on, what am I supposed to do, what are the next steps, what are my diagnoses. And a lot of times, one is the workflows of, well, we've never done this before. We've never shown the patient that they have a diagnosis of obesity. What if they say, what,
It's just like bringing a patient in the boardroom. Well, we've never done it. We're the fear of the unknown.
But Dr. Chris Tash and I was visiting Wisconsin earlier this week, and he said, I have now 1,000 fact checkers because nobody cares. Because nobody cares about the accuracy of their information more than the patient does. Absolutely. And he said, there is not a week that goes by when someone doesn't fix my records and update my records because I give them what I think, for example, their medication list is, and they correct it. And he talks very highly of this simple piece of paper.
John.
At the beginning of every flight, most people want to be sophisticated and ignore all the information about the doors and all this stuff. But, we've learned to talk to our passengers. And we've learned to talk to them sometimes very aggressively and appropriately so. I know one flight attendant got in a little trouble for saying, listen up, folks, this is not your living room. But the fact is, every hospital in the United States needs to have a protocol and a videotape and a capability of sitting the patient and the patient's family down and saying, you are an integral part of the safety system here. This is an incredibly complex human system, and we need your eyes, your ears, and your brain. Here's how to talk to us. Here's how to interface with us. Here's what not to sit there and wonder, should I say something? Right now, only a couple of hospitals have done this, and most of them who have done it got so wrapped around the axle with their legal department that they pablumized it. We need aggressively to make, pablumize. It's a new verb.
That's very good. Hey, watch out. He's a lawyer. They invent words. Absolutely, John. I'm watching our time. David, you wanted to add something.
So Wednesday morning I was seeing patients, and to go back to what Farsad was mentioning, there were 2 instances in which a patient came to me at the end of the visit and said, hey, what about this item that I had forgotten? And if we do have a partnership like that, everybody will be better off. Now, we've learned an enormous amount from aviation in healthcare. And we've gone a couple of years in which there were no deaths related to commercial aviation in this country. It'll be a while before we go a year without a death related to medical care in this country. And
Did you say minutes, or how long did you say?
right.
Oh, okay.
You know, we recognize that there's just that there is an awful lot to learn. We've one place we've utilized this is around team training. So many of the, for example, in the operating room, surgeons do better if they go through some team training before operating. And I think that there are an enormous number of lessons that we have to learn and that we have to bring into electronic records. I'd go back to what Farzad said before in terms of it's not if medical records will improve safety, it's how do we do it most effectively. And then how when we've learned those things, how do we share those lessons?
It's far beyond, as we all agree, IT. For instance, it took 10 years, and God only knows how many people died from the injection, unintended injection of undiluted KCl, potassium chloride, before we finally got it as to the #1 hit list position with the Joint Commission. Here we are now, what, 15, 18 years down the road from that, and I understand there are still some hospitals using undiluted KCl or having it on the units. The ability to be able to get information out, like we do in aviation, many things to learn from this. If something happens this afternoon in the utilization of a 737-500, 700, 800 that we find problematic, by tomorrow morning every operator on the planet Earth will know about it and know what to do about it if we have a solution. There's no reason we can't do that in healthcare, and as a matter of fact, I think it's a very severe moral obligation.
So one thing I want to come back to Sully in that you and I were at a meeting that had an equally prestigious group up in Boston, and it was a time when you and I prepared together and I went through the literature with you, and I thought you brought up a sensational point that kept everyone riveted, because Sully described his 208 seconds. And he described how these aviation methods in the socio-technical model framework, how the structured language and how the systematic approach to things and how these things created capacity for you to do something novel that you'd never done in a simulator, because you'd had ingrained together with Jeff, you were working together as a team in a good, solid socio-technical model, thrown a total curveball that wasn't one you'd seen before. Would you describe that, and also so that people could understand how much resilience it gave you and what happened to you physiologically with your vision and everything else in those 208 seconds? Because he had us riveted, because we really could understand how these systems, this invisible safety net that Sharon talked about in our movie, how this invisible safety net kept you afloat in 208 seconds. Would you go through that? Because we have a few minutes to do that.
That's a long story, but I'll make it brief. We had this safety system that we had created that allowed us, based upon what we did know, to apply this knowledge in a new way to solve a problem very quickly that we'd never seen before. And we had a well-versed team who were trained in the consistent application of best practices, with well-defined roles and responsibilities, with a clearly defined vocabulary, a truncated vocabulary, but words rich with meaning. For example, the word brace, which I used in that one brief announcement to the cabin, triggered in the cabin crew, the flight attendants, their actions to shout over the intercom to the passengers, brace, brace, heads down, stay down. And even though I'd only met the first officer 3 days before, we were so well trained with such well-defined roles and responsibilities that even in this novel situation where the time pressure was so extreme that he and I never had time even to discuss our situation or what we were to do about it, we were able to collaborate in those 208 seconds wordlessly. I was able to rely upon him immediately and intuitively understanding this developing situation as I did, knowing what he needed to do, and then have him actually do it without me having to direct him because I didn't have time. A good example of that is late in the flight, before the critical maneuver, which was to judge the height above the river visually, at which I would begin to raise the nose to achieve the proper rate of descent, speed, and attitude for landing. And this had to be done very critically, I mean, literally within a fraction of a second. Had I begun to raise the nose too early at too great a height, we would reach this attitude too far above the river and lose lift and drop on hard. If I waited too late, we wouldn't get the nose up. We would not have reduced our rate of descent sufficiently, and we would hit too hard. And so Jeff knew, again, without me being able to tell him, having a chance to tell him, he needed to shift his priorities. So he stopped trying to regain thrust from what turned out to be irreparably damaged engines, and he's chose instead to call out to me airspeed and altitude above the river to aid me in that critical decision-making process at the last moment. So we had this huge obstacle to surmount, but we weren't starting from the floor. We were starting from here because we had created this system, this platform to operate from. And it was actually, paradoxically, our insistence on procedural compliance that allowed us to innovate by taking what we did know and applying it very quickly in a new way.
So I want to go to David and then to John. So David, what we just heard were that the training, the preparation created a capacity for dealing with something novel, and the part physiologically, you felt your vision narrow, and physiologically you didn't kind of stabilize for months. So we know that this was not a walk in the park, yeah. Right? This was sheer terror.
I felt even in those seconds my blood pressure, my pulse shoot up. My resting pulse is normally around 68. For 10 weeks it was 100. My blood pressure is normally 110 over 70. For 10 weeks, it was 160 over 100. I mean,
and you didn't sleep for?
I didn't sleep more than a few hours for days at a time. It took about 3 months for me to finally.
So under that intense pressure, the training was there. So I come back to David and I say, okay, we've got these wonderful IT systems. Let's pretend we have enough money to buy whatever we want. And so many of the vendors say, we like the big bang approach. Let's go in there and turn CPOE on 5 hospitals simultaneously and gut our way through it. The issue is that our clinicians and our administrators and our folks out at the front line, not at the Brigham where you have fabulous, I mean, Brigham, Mayo Clinic, Cleveland Clinic, you all have far greater resources than St. Elsewhere out at the front line. Without an NTSB approach, without a way of sharing learning, are we really prepared to go flip on all the switches and pretend like everything's going to be safe?
It would be exceptionally risky to do that. We saw that no one raised their hand earlier, and we have evidence actually from a number of stories and studies that do show that there can be adverse consequences, including increases in mortality rate. So it does not make sense to do it that way. Now there are a set of good principles for implementing computer order entry, but for example. But they involve taking a measured approach, finding out what the issues are, going through, dealing with them in a systematic way, and just making sure that you're on course.
So, as we proceed, again, in our earlier sessions, we talked about an NTSB for healthcare, which is really just something that we can look at as a framework. Were we asking for an agency to be funded at a time when we have no money and $100 trillion unfunded liability? No, our article with Sully and John Nance and Dennis Quaid in our next article, that'll be a second part to it, isn't saying go spend a bunch of taxpayer money. It's should we do this? And really not should we do it, but who could debate not doing it when it works? And the answer is I think it's, I just can't believe anybody can say there's not enough evidence, meaning that, well, if you do a literature search on NTSB, I don't see a randomized prospective trial. Give me a break. 25% of what we do is in the literature, 75% is habit. It's just impossible. So I'd like to come back to John. I know you had a comment, and Farzad, I think you have. I'd like to come back to the risk issue of deployment because we have 3,100 hospitals in our research test bed. I hear every day the fear of the risk of turning things on, and we know after the election we're going to have budget cuts, and they're going to be partway through an IT implementation. They want to get their meaningful use money, but they're going to cut training. I mean, to me, there just isn't enough money there. So what do we do if we don't learn from aviation?
All it would take is a short number of so-called red cover reports focusing on the very sort of disasters that we know occur out there all the time that we haven't learned from. And one of the things we can get from it is what I have derived from your experience, Sully. And you were talking about it, and my methodology of discussing this is minimization of variables. We need to minimize variables all over healthcare. Even before we put in standard methodologies, if we minimize, you go into the operating room, and there are preference cards that have so much unnecessary garbage on it. Would anybody fly with me as a captain if I had a preference card? I mean, you know, I do it this way. I don't put the gear down automatically. I mean, this is ridiculous, and yet we haven't.
Sully's told me that you used to have him as a second officer, and you had to carry him around with the captain just so that you could get promoted, right? So you had to fly whatever way the boss flew.
One of the reasons we went 5 years without killing a single passenger in the U.S. between 2001 and 2006 is because we got rid of all that philosophy. We minimized the variables. When he and Jeff had to make this incredible 208 seconds work, they were unloaded. You correct me if I'm wrong, you were the one there, but they were unloaded with having to reinvent the wheel. They knew what it would take to put it in the water. They knew what it would take to glide the teeter-burr. They had to make a decision between the two. If they were garbaged up with all the things that they'd have to reinvent, like the average preference card and the average nurse trying to set up an OR, I'm not sure that you would have had the same guarantee of the right decision. But the matter is, we have learned the hard way in aviation and in nuclear power and in NASA and on, that if you minimize the variables that a human being has to deal with, you maximize the opportunity for cognitive brilliance, education, and training to come out at the critical moments. And that's platinum and gold.
Farzad, I heard the glowing, here's all the good things we can do. What about the risk?
Listen,
tell us about the HIT
The question is not, and we talked about it earlier, the question is not whether we move forward on adoption. Now, that die has been cast. For many of these groups, the question is not whether they move forward. It is not the time to say, well, let's wait. Let's wait for better systems to be developed or whatever. The question is how. How do we do this in a way that's safe? And honestly, sometimes doing halfway implementations is the most dangerous thing that you can do. To implement a system halfway, to live in a hybrid world where some of your processes are paper-based and some of your processes are electronic, is the worst of all possible worlds. The question is not whether we move forward on implementation, for example, of CPOE or of decision support. The question is how do we do it in a way that is the safest way, that is the most effective way possible. We were talking about the medication-related safety issues. And you know where a lot of the problems come is when you make electronic one part of the process, and then there is a human gap. In Chicago, there was a child that died because they ordered the system in a CPOE system electronically, and then they were transcribing by hand that electronic order into a medication dispensing workflow.
So let's take that. Let's take that because of time. We're gonna. So let's come back. So that's a great example. That's a great example of where training and understanding the risk of adoption is a really key issue, because I'm going to come back like a dog on a bone to 30 preventable deaths an hour. We're not really here to write a paper. We're here to say 30 preventable deaths an hour. My little boy that was here at this meeting had 2.2 times the anesthesia that he needed, and he was sitting on my lap, and I couldn't have stopped it because they failed to convert kilograms to pounds on a piece of paper. And so the training and the preparation, what could we do now? What can we do now?
I think a very big thing that we can do, which the Office of the National Coordinator has pushed, is to help figure out what the key decision support is and how we share that. And just for example, one issue that every organization has struggled with is which drug-drug interactions do you display? Farzad's agency sponsored our group in RAND to develop a list of the most important drug-drug interactions. They're ones that should never be overridden. That was just published actually in the last day or two. And that's something that every organization can take. We need to do this across an array of domains, but this is one, I think, really positive example.
So that kind of low-hanging fruit coupled with reports of here's how it can go wrong and here's how it can go right, I think fits in the red cover model. I think we're at time. This was a great panel. Thank you all. I think we heard some really practical things. Thank you.